Hello, I'm Dr. Ivona Igerts. I'm aesthetic medical practitioner for 25 years. We are here in Wigmore Training Center, and today I want to show you face design. I'm here with my beautiful patient Joanne. She had a little bit of hesitation on Friday. She was worried how she's going to look like, because not only that she's beautiful, but she's also acting, and for her it's very important to preserve her original beauty and maybe just meticulously improve her already beautiful face. We decided to do little improvements in her upper facial third, middle facial third, and the lower facial third. So how to define her face? She has an oval shaped face, which is absolutely the best shape for a woman, and I will now describe mathematics and geography of her beauty. So when we think about Joanna's face, we want to analyze it in horizontal thirds and later on vertical fifths to see what we are missing in the symmetry. So when I talk about horizontal thirds, then I start with trachyon, and here we have glabellar line, subnasale, and mentum. So upper third is most dominant third in Joanna's face and is beautiful and concave from her oblique side and also from the lateral profile. So there absolutely nothing to improve because it's already beautiful. Only thing what I can do in her upper facial third is play around with the eyebrows. So frown for us, please. Here we see tiny bit of 11 lines, and because of contraction of her corrugator muscles and procerus muscle, frown again. Procerus muscle is normally leaving the little tiny horizontal line on her nose, which is nearly invisible. 11 lines come from corrugator muscles, and here is the tail of corrugator. So I will do tiny bit of injections of neuromodulator exactly there to not to freeze Joanna's face, because remember she's acting, so her face should still move. Mimics and expression are very important part of individual beauty of our patients, and in my opinion it's very wrong to freeze face using neuromodulators or any injectables. So we have to understand her mimics and actually just relax a little bit of muscles and play with the muscles on the way that we get enhancements with eyebrows on the upper facial third. So what I really want here is to lift her eyebrows, because key feature on Joanna's face is definitely her beautiful eyes. So we will lift the lateral tail of the eyebrow by injecting tiny bit of neuromodulator just beneath her eyebrows. Smile for me. And you see nearly invisible crow feet. So Joanna's biological age is 43, but I would say the way how she looks and radiance of her skin, as well as no static lines showing, she looks much, much younger than her biological age. On the other side, tiny bit of neuromodulator, and here maybe a bit more. On that way I will get her lateral canthus enhanced and her eyes more opened. As we see here, there are little tiny lines, so whatever I will do, I will use neuromodulator Latibo. I will dilute it with 1 ml because it's 50 units, and I will use tiny micro droplets of that neuromodulator on the way that I just relax her face instead of getting her not nice frozen look. So here I can see also tiny bit of bunny lines, so lines which come in contraction of nasalis muscle. So try to, so we see it here just beneath the procerus line. Here goes nasalis muscle and tiny bit of lines which we can also relax. Then the middle facial third of Joanna is beautiful, but we see tiny signs of aging. When we think about dropping of her face, we need to analyze Joanna's fat pads. We have two types of fat pads. We have superior fat pads and inferior fat pads. So inferior are next to the bone and they are usually just going into depletion slowly, while superior fat pads go in atrophy, hypertrophy, they are moderating, and this is something which is changing our outlook of our patients, and they usually say and comment like Joanna just did, that something is dropping in her mid-face and she wants her face up. I will now mark the ligament line on Joanna's face, which I always do, because it's very important to understand that historically, in ancient times, occipitalis muscle and masseter muscle, which come on Joanna's face behind that line, so laterally of that line, were giving to the face statics and strong biting, grinding. So on that way, our ancestors were surviving. While this area, which goes in front of the ligament line, is the area of showing expression and mimics. So face has 43 muscles. Those muscles are innervated by trigeminus nerve, while muscles of mimics and expression are innervated by 7th cranial facial nerve. So we have to be careful to keep this area as a very static area with tiny bit of lift, while this area is dynamic area, which is important for Joanna to talk, smile, move, and actually express herself. Here we see nasolabial fat pad, which is a bit sliding, so there is tiny bit of prolapse from the ligament line, we can see down to medial line, and hypertrophy of nasolabial fat pad. While here is tiny bit of depletion of Souf's fat pads. So we have to restore her face, restoring the fat pads of Souf, which means infraorbital, deep fat pads. And also on zygomatical line, we should do a tiny pull. On that way, she will get rid of her nasolabial fold. Let's go on the lower facial third of Joanna. So lower facial third is the facial third which is always showing age with ladies and men after 40. What is actually happening in the lower facial third? In the lower facial third, the depressor muscles, so muscles which pull down our face, are started to work stronger. They are anyway massive muscles, much stronger than elevator muscles. Depressor angulae oris, here, mentalis muscle. Now try to pull down your lip corners, please. Yeah, so we see here the depressor line, we see activity of mentalis muscle. So all these muscles are definitely pulling her lower facial third. Can you do it stronger, please? Yeah, and we see here how platysma is active as well. So what I'm going to do, I'm going to knock down or just shut down a bit those muscles together with platysma neck muscle, and platysma starts on clavicular bone and ends up above her mandibular line. On that way, I will give possibility to elevator muscles of Joanna face to work stronger and just to bring nice enhancement. So we want her lip corner to lift up, and we want more enhancement on her jawline. Enhancement on her jawline we are going to do with neuromodulators, as I said, knocking down the platysma muscle, and also with projection of her gonial angle, which is somehow not projected enough. So I want to restore her gonial angle. This is normally 120-degree angle in the face. And this is going to bring nice pull back to lower facial third, as well as better enhancement of the jawline, of the place where jawline matches the neck. The other thing what is very important to understand, I will need to do superficial injection of the temporal cheek fat pad, which is on a vein depletion. So by doing that, by reconstructing the gonial angle and by reconstructing the cheek fat pad, cheek temporal fat pad, I will get even better and stronger pull. So let's analyze Joanna profile. So when we see Joanna profile, we can say that when we think about Joanna profile, we want to think about Ricketts line or Starner line, but I would like to take Ricketts line. It's somehow easier I'm using it for a long time. So in her profile is absolutely beautiful. So tip of the nose, upper lip, lower lip, and her chin are aligned. So there is no need of anterior protrusion of the chin. I can just enhance the position, which is automatically going to happen because of neuromodulators into her mentalis muscle, but maybe I add few droplets of hyaluronic acid as well. On that way I will shape the chin better, but no need of extra chin extrusion. So very important part of our work is asepsis. So we want our patient to be ideally without makeup. And after that, we clean the face, disinfect the face, and apply numbing cream, which is going to be on her face. This is 5% EMLA, so lidocaine. And this is going to be on her face for another 20 minutes. In the meantime, I colored some blood vessels on Joanna's face so we can see the areas which I would say we should avoid as beginners, but later on we can treat, but with, let's say, more precaution. So we should aspirate more, even though I always say aspirate everywhere you are, because you never know, anatomy is varying from patient to patient. So here we can see our facial artery that crosses on the masseter, anterior masseter border, crosses mandibula, and it's a very elastic artery. So the most elastic artery we have in our body. And this artery, 1.2 centimeters from the angulus of angulus oris, is giving two little tiny arteries, infralabial artery and supralabial artery. And after that, goes to the nose. First is very deep and then becomes more superficial when it's close to Alenasi, and gives a lateral nasal artery and finishes in terminal branch of angular artery. So this anatomy is very important to know, and as well very important to avoid. So novice injectors should not, in my understanding, go and run into the nose, even though I saw on Instagram, on TikToks, pretty much people doing it without aspiration. I think it's very special anatomy here, and we have to respect it, because always we have to think about patient safety and secondary beauty. So this is our facial artery. So facial artery anastomosis with ophthalmic artery and catches up into dorsal nasal artery, which is very dangerous. So if something goes wrong in this area, in this angulus here of injection, we can cause blindness. Blindness could be also caused by superficial temporal artery, which is coming like the terminal branch of external carotid artery. And it's again, temporal fossa is the area which we have to take special precaution, because we have superficial temporal artery as well as temporal vein. Carotid artery gives us zygomatical orbital artery, which goes directly on the face. Here mostly we are quite lucky because zygomatical arch covers this artery, so it goes deep. So if we inject directly on the arch, we are not in a big danger, but again, aspiration is always needed. And we have transversal facial artery, which is again something that we have to take care about. Then very interesting thing of our anatomy is the notches. Supraorbital notch, infraorbital notch, and mentalis foramen. They are all aligned in a vertical line. So here, on supraorbital notch, we have supratrochlear artery and nerves coming out on the face. Again, Instagram and all the social media are inspiring injectors to inject dermal fillers in this area. I think it's again very, very dangerous, because if we know our anatomy, we know that this supratrochlear artery is actually connected to ophthalmic artery, which is feeding retina, and this is the only blood vessel that feeds retina. So if something goes wrong in this area, just a tiny compression of the blood vessels, already we are obstructing the vision. Infraorbital artery finishes on the face, comes out through infraorbital notch, and this is a terminal branch of maxillary artery, as well as we have mental artery coming out on the lower facial third. So this is the anatomy where if we are novice injectors, we should avoid, but if we are injecting long time, always have a special precautions and aspirating more around this area. So now I will show you face design on our beautiful Joanna. And as we analyzed her face before, we decided that on the upper facial third, the only thing I'm going to inject is neuromodulators and the soft injection where I am going to balance, lift up her eyebrows, lift up her lateral canthus, and on that way get her stunning eyes even more enhanced, position of them, and eye opening. All ladies like when the eyebrows are a little bit higher. And then we have mid-face, which I need to restore. I need to reconstruct the infraorbital fat pads, deep infraorbital fat pads, which are a little bit depleted. And as well, I want to protrude a little bit of her zygomatical line. So from her oblique side of view, it's important that we have OG curve intact, which means it starts on the temples. You see she has beautiful temples, but then we lose here tiny bit of that OG curve, and that needs to be restored and sharpened. And then after that we go on to the lower facial third. We pull back the skin around her ramus of mandibula. We protrude her gonial angle, and she's going to get very nice and tight lower facial third. So let's do it. I draw the line in between the lip corner and the lower part of her ear, and I mark out my tear throw area. So I'm not a big believer into putting a lot of hyaluronic acid inside of this triangle, tear throw valley, because I truly believe that if we enhance and pull back, as you can see here, and restore the cheek fat pads and SUF, it's going to be more than enough. So we don't need an extra volume there. There the skin is thinner, 15 times than anywhere else in the body, and sometimes we can do more complications to the patient, lymphatic drainage complication, obstruction of lymphatic drainage, some edema, or even Tyndall effect. So at the beginning, I want to reconstruct all the mid-face, and if I need something extra in tear throw area, I will happily do, but not immediately start with tear throw area. So I decided to inject in the mid-face Voluma product. This is the product which is volumizing, which has cross-linkage in it. It's hyaluronic acid 23 mg per ml. It's strong enough and it's easy and beautiful to mold under your fingers. This product I don't use with vasoconstriction because I will use more different injection points, and I like my patient to be as safe as possible. So some people are even allergic on lidocaine, we never know. And as well, I like pure hyaluronic acid. So we used to have hyaluronic acid from chicken comb. And what I like to do, as I always said, safety is very important for me, for my patients. So I prefer without lidocaine, and also I prefer pure hyaluronic acid, not delivered by animal origin. So DNA constructed hyaluronic acid. And the hyaluronic acid, which is monophasic rather than biphasic, and easy being molded under my fingers. So I'm disinfecting her face one more time. It's not good for the patient that I pass through my needle, which is sterile, on the markings. So I'm removing all that. And here we go, we start injecting. So she will feel a little bit of push under her skin. How you feel? Mm-hmm. She feels okay. So as you see, I love my patient standing up. That's my way of work. We go another time. I leave the bolus of 0.1 ml just to be safe. And we know that here there is zygomatical orbital artery, which is going under her zygomatical cheekbone. So we see already how we got a little beautiful lift on her cheek. So now I want to enhance that even more. Slow and steady injection on the bone. Now we go into nasolabial fold, apertura piriformis, which usually loses the volume. So that's going to be a little bit more painful. So I'm here next to Alenazi. I put my needle, aspirate, wait, because you never know. If you're in blood vessel, you need to wait another extra few seconds after aspiration. And here we go. The anatomy to avoid in this area is facial artery. Labial fold, I'm going to just give tiny bit inside. So under 45 degrees, I go under the skin. Always aspiration and fan technique of injection. Just to improve it slightly. I personally think and believe that nasolabial fold is mostly improved by mid-face augmentation rather than injecting into the fold itself. We go just to improve the shape of the chin. As we said, out of Ricketts analysis, she does not need any extra anterior projection of the chin. But she can profit a bit from reshaping it. So in her case, we watch Alenazi because she's so beautiful and the oval of the face and the shape of the face is oval. Relax, darling. So Alenazi is our marker to inject her chin. We don't want to go wider than that because then the chin will be too strong for her facial features. On that way, it will stay just ideal projected. So let's go now from the lateral profile. We see how we got a nice OG curve here, which we can nicely follow. Later on, I will add an extra pull with a thread, but not, right now I'm concentrated on the lower facial third. And I want to check where is my gonial angle. We can see it here. So I am palpating the gonial angle. I'm going directly on the bone. I touch my bone, I aspirate, and I put 0.2 ml bolus on the gonial angle. On that way, I will get it more protruded. Here we come to the pre-jaw sulcus, which needs some extra work. And always when we are here, it's nice to be directly on the bone. So I go deep, I touch the bone. And I leave my material. This little bit, what is remaining, is actually platysma muscle. So later on, when I inject neuromodulators into her platysma muscle, and when I enhance extra everything with few threads, she will be totally okay. So for neuromodulators, she needs to wait 3 to 4 days that they kick in, and then we will get this area very tight and nice. Here, the anatomy we should avoid is definitely parotid gland. On gonial angle, we have a deep injection. Later on, is more superficial. Now we want to do a little bit of support of her lip corner because we see that there is tiny depletion of fat pads around. And again, we just want to support. And on the contralateral side as well. Quite beautiful and continuous line we got. So her chin, which I started to mold by the Alenazi projection, and then I enhanced the area and supported the lip corner. I blended it totally into her jawline. So it looks really nice. Important thing for the face is that we have continuous line. So continuous line in the mid face, continuous line in the lower facial third. On that way, we get the best improvement. My personal preference is to inject lips always on the end. So when I scaffolded all the face, so when I got my my projection of the most important facial lines, like zygomatical line, then the jaw line, when I got the Ricketts line correct, then I have strong support to inject the lips. When we think about Joanna's lips, they're beautiful, they're full. She did not have any injection for longer time, right? Like
2022.
2022, so which means 3 years. But still, there is a little bit of possibility of improvement. So blow kiss for me, please. This is how we want to analyze lips. Smile for me. Always out of every structure. We have to see that when she's smiling, when she's moving her lips, she still looks natural. So we don't want to make a filler injection on the way to hide her upper teeth. The upper teeth, when she's smiling, they still must be visible. So whatever I want to do is actually improving her middle part, her cupid bow, and as well middle part of her upper and the lower lip, and also bring a better proportion there. I love to do golden ratio proportion with lips, which is 1 to 1.6. So Joanna had enhancement done to her lips 3 years ago, right? And do you remember what product you used?
Yeah, I think it was Chroma.
Chroma. So it's always best and safest for the patient to keep with the same product because hyaluronic acid blends better to certain hyaluronic acid from the same production house, but also is very, very safe. So we never know when we mix products what is actually happening under the skin. 50 units of neuromodulator. I will remove the plastic cap. I always try to clean rubber before entering there. And also I disinfected prior the sterile saline. So I inject inside and I will withdraw. My preference is to mix it with 1 ml. And we see how it's getting in under vacuum. It's brilliant, it's low, it will not create any extra bubbles, and it's just getting inside slowly. I will prepare the neuromodulator for the upper face, as well as for the lower facial third and platysma. A lower facial third. Here we see activity of mentalis muscle and depressor angularis muscle. So we can follow this imaginary line of nasolabial fold and line what depressor angularis muscle is doing. And so where they cross, I will put and inject 3 units. Some injectors go very high up, which I'm not a big friend of because we come too close to modiolus, and on that way the toxin can spread into risorius muscle or any other muscle catching up on modiolus. So keep your injection low, like 5 millimeters to 1 centimeter over the rim of mandibula, but also as lateral as you can, because here we have depressor labii inferioris muscle, which we don't want to hit with neuromodulator. Do again the movement, relax. So now I go deep on the bone and I position 2 units per injection point. Again, try to be away from depressor labii inferioris, otherwise you will produce a crooked smile. Let's go on to depressor angularis on the other side. Please do the other. Yeah. So we see here this little tiny pool of depressor muscle. I will catch it down just on the platysma border. Let's do again the movement. You see how she's pulling with platysma as well? So this is what I want to, again, get the moment. I put 5 units per injection point and I knock down this very strong vertical band of platysmal muscle. So 5 units per side. And again, platysmal band which is connected with the depressor angularis and makes this downward pull. So we want to get rid of this area, of this part of sagging jaws. So go all around jawline, around her gonial angle, because I want to extra enhance this area. If my patient would lay down, I would not be able to distinguish clearly all these muscles which are mixing, which are confronting each other in the lower facial third. And it's very important to know that these muscles are in different layers. I still have 5 units of botulinum toxin neuromodulator in my syringe, and then I decided also to inject tiny bit into nasalis muscle, its ale part, because when Joanne is smiling, she's widening this ale nasi. 2 units will do magic there. So she has a beautiful nose, Frontonasal projection is amazing. Her tip of the nose is amazing. Just really beautiful nose. The only thing I see when she's smiling, there is a little bit of extra movement there, what we could control with neuromodulator injection. So this muscle is positioned very superficially, so no need to go deep. So now we did injection for platysma muscle that starts on clavicular bone. When we do vertical bands of platysma, we don't go lower. We don't want to target also the lower part of platysma muscle. It's not necessary and it can be very inconvenient for our patients. So let's keep upper part of platysma and around jawline. So in that way she will have even more enhanced gonial angle. I injected depressor angularis mentalis, so the pull is not going to be there. When I knock down depressor muscles, her elevator muscles, so her beautiful zygomaticus minor, zygomaticus major, will pull up even more. They will get possibility to lift her face even more. So whatever we did now with dermal fillers, 23 mg per ml dermal fillers in her face, is going to be enhanced more by work of neuromodulators. So we go on to upper facial third, injection on the bone, aspiration, and I will position here 8 to 10 units into her procerus muscle. Then we go 45 angle needle. We always protect the orbital rim. We know that here is this humble anatomy of supratrochlear artery, so with Botox is safe, with neuromodulators is safe, but with filler would not be so safe. Anyway, I don't want spreading of neuromodulator beneath this line, so I'm always protecting her orbital rim with my non-dominant hand. Aspiration, and I put 5 units here. Again, I go on the other side, aspiration in her corrugator muscle. Best that the patient is always doing movements on the face. So you can see where is frown again. So you see the tail of corrugator muscle. Tail of corrugator muscle is a very superficially positioned in the dermis itself. So we don't need to inject deep. We have to stay superficial, and tail is not so strong as the head of corrugator. So 2 to 3 units will do. Remember, I don't want to freeze her face. I just want to shut down on the strong mimics. So lift up your eyebrows, please. And those lines, tiny lines, we will also inject with micro droplets. We have to keep 2 fingers above, not above eyebrows, but above orbital rim. So we don't want to inject lower than that, because we can risk into droppage of her eyebrows. Instead of lifting them, we would drop them. So we have to protect this area. So I will position 2 units per injection point. And now we go into lifting. Smile for me. So I love to do micro droplet injection, and I will go all around her tail of eyebrow. Let orbital rim be a marker, because nowadays ladies plug their eyebrows and they have permanent makeup, so it can't be our landmark. Keep the bones as your landmark. This product is softer and it's not so cross-linked on that way, because we all know that lips don't have keratin layer. I will pretend risk of getting over injected lips. So the product I will inject with plaster vertical technique into her lips, and I will target mainly the mid area. I want to get a better projection of lips, like upper lip to lower lip 1 to 1.6 ratio. And still I want to enhance the lip corner. I want to enhance with lips is definitely Cupid bow, which is here. I want to enhance the lower lip, so we see that a little bit of volume is missing here. So this projection would be nice. I will inject quite superficial, not too deep. We know that here we have infraorbital, infralabial and supralabial and infralabial artery. And also I will consider the lip corner. So ideal position of the lips normally is from pupillar line So we see that Joanne is nearly into ideal golden ratio proportions. So I will use the vertical pilaster technique. So my idea is just to enhance and again to lift the lip corner as much as I can. Lips look a bit distorted. This is because of dental block or infiltrative anesthesia she got before, and she will need around 2 hours that this completely wears off. So face design is nearly finished now. We addressed all the facial thirds of Joanne, upper, lower, and mid-facial third. We addressed platysmal muscle and her neck, jawline. We positioned right the gonial angle, and there is a right proportion in between her zygomatical bone, gonial angle, and temples, as well as from oblique side and from the lateral side. So she got nice lines, nice main facial lines. From oblique side, she got beautiful OG curves, so her geography of face is stunning. And now I want to finish everything, and good face design should be finished with rejuvenation, so with anti-aging, with prevention. One thing I love so much is the product which is bringing hydration to the deep tissues of our skin. This product has hyaluronic acid pure with glycerol. So hyaluronic acid is binding water while glycerol is calling in for water. So it's a beautiful combination to get her skin shiny and glowy. I will also use polynucleotides, special ones for around the eyes, so that she does not have any extra edema around the eyes. So we have special polynucleotide just around the eyes area, and also tiny bit of polynucleotides on her neck and on her lower facial third. I will, to enhance extra, use little mini threads which I will position around her jawline, gonial angle. Mini threads are beautiful, and they are made of polydeoxynan material, which is actually what we use for suturing. They are going to disappear under Joanna's skin after 6 months, but they will boost Joanna's collagen, so she will have an extra improvement later. I will put into her mid-face, in the mid-dermis. I'll put around lower face, as well as here. Now we will position polynucleotides. We have two types of polynucleotides. One which is better to be injected around the eyes, does not cause extra edema, softer version, and the standard version which I will inject in the lower facial third, mid facial third, and tiny bit on her neck. Finish face design today. I decided just to inject tiny little mini collagen threads around her jawline, so to be sure that we did the best possible for the jawline. We tighten it with botulinum toxin, with dermal fillers, and then at the end we will add little tiny collagen threads, and the results are going to be amazing. So I'll find right vectors, so just to enhance her gonial angle and scaffold her skin. I have a special treatment called spider web facelift. So we rotate and remove the threads, and we leave under the skin little PDO implant around which new collagen is going to be created. So on that way, for rejuvenation, we were using hyaluronic acid for deep hydration with glycerol. Glycerol was signaling water and hyaluronic acid was binding water. Polynucleotides for cell rejuvenation, so on DNA level, and little tiny polydeoxynan threads for, again, stimulation of collagen production. So we see that in the best rejuvenation, it's good to mix and match and tackle the collagen production from all different angles. So we finished today with our brave Joanna. We did for her face design treatment, so rejuvenated her face and meticulously improved all her beautiful facial thirds. So she was beautiful before. but now she's going to be exquisite. And also we ended up with a beautiful rejuvenation treatment where I used hyaluronic acid pure with glycerol together with polynucleotides and mini collagen thread. Thank you very much. And if you want to learn more about face design treatment to make your patients more enhanced and also rejuvenated, please come to Wigmore Training Center.